શું કરે? ઓકે. ટ્યુશનનું શું કરશે? હા, એ ટ્રાન્ઝિશન છે. હેલો 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 ટેસ્ટિંગ ટેસ્ટિંગ ટેસ્ટિંગ. ડીલે છે ને એટલે આવી ગયો ને ભાઈ.
Our chief guest for the day, Dr. Anup Tosnipal from Aurangabad. Our guest speaker for the day, Dr. Philippe Moreau from France. Our guest presenters, namely Dr. Mallikarjun Karashetty and Dr. Siddesh Kalandri. All our discussions were themselves very eminent hematologists as well as hemato-oncologists. And you participants for spending the Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, it is 26th of October 2024 from 7 p.m. Indian Standard Time onwards. We have Professor Dr. Gautam Bartakar from Houston, USA, speaking to us on acute myeloblasttic leukemia, unusual situations. And the following day, that is Sunday, 27th of October 2024 from 11:30 a.m. Indian Standard Time and 7 a.m. Italian Time, we have Dr. Maria Domenica Capellini from Milan, Italy, speaking to us on innovative treatments for rare anemias. Let me introduce our discussions for the day, and we have galaxy of them here displayed in alphabetical order. I will just name them in the event of time. To start with, we have Dr. A.R. Jaswantini from Hyderabad, Dr. Abba Dubey from Ahmedabad, Dr. Aditya Jandial from Punjab, Dr. Ishwarya Raj from Ahmedabad, Dr. Akanksha Garg from Ahmedabad, Dr. Ambar Garg from Raipur, Dr. Anil Singh Airom from Imphal, Dr. Ankit Batra from Dehradun, Dr. Ankit Rayani from Ahmedabad, Dr. Aryan Jain from Chandigarh, Dr. Arun V from Mysore, Dr. Ashish Dixit from Bengaluru, Colonel Dr. Ashok Meshram from Kolkata, Dr. Avriti Baveja from Dehradun, Dr. Bhavin Shah from Ahmedabad, Dr. Chirag Shah from Ahmedabad, Dr. D.S.K. Sahitya from Vizag, Dr. Dinesh Burani from New Delhi, Dr. Dinesh Sheth from Bengaluru, Dr. Fahima Hassan from Prayagraj, Dr. Gopinathan M. from Chennai, Dr. Hari Menon from Bengaluru, Troop Captain Dr. Harshit Khurana from New Delhi, Dr. Neemya Thanda from Myanmar, Dr. Kartik Purohit from Vadodara, Dr. Ketan Modnak from Nagpur, Dr. Kunal Goyal from Navi Mumbai, Dr. Kundan Mishra from Lucknow, Dr. Khushbu Jain from Aurangabad, Dr. Mohammad Mir Hussain from Srinagar, Dr. Narendra Agrawal from New Delhi, Dr. Nilesh Vasekar from Nashik, Dr. Nitin Gupta from Delhi, Colonel Dr. P. Suresh from Delhi, Dr. Pavan Kumar Singh from Gurugram, Dr. Priyanka Srivastav from Gujarat, Karamsad, Dr. R. Prasanna from Tamil Nadu, Dr. Rajan Yadav from Ahmedabad, Dr. Ramesh Balasubramanian from Madurai, Dr. Ravi Kiran Bonanthia from Hassan, Karnataka, Dr. Rupam Deka from Guwahati, Dr. Sandeep Shah from Ahmedabad, Dr. Sanket Shah from Ahmedabad, Dr. Satish Kumar A from Yashwantpur, Bengaluru, Dr. Sudarshan Pandit from Nashik, Dr. Uprendra Sharma from Jaipur, Dr. Yashwant Kashyap from Raipur, Dr. Yi Montan from Myanmar, Dr. Yaglakshmi Shiva Prakasam from Hyderabad. Now it's a time to introduce our special guest and chief guest for the day. We have with us Dr. Anup Toshniwal from Aurangabad. Dr. Anup Toshniwal is consultant medical oncologist and hemato-oncologist, director, founder of Shri V Care Clinic at Chhatrapati Sambhaji Nagar, Aurangabad. He did his MBBS from Government Medical College, Aurangabad, followed by MD Medicine from Kasura Medical College, Bangalore, followed by DM in Medical Oncology from prestigious Tata Memorial Hospital, Mumbai. He subsequently cleared the European Society of Medical Oncology examination and was awarded fellowship for clinical research from Australian Clinical Oncology Research Society. He is also an executive committee member of Western Zone, Indian Society of Medical and Pediatric Oncology. He is a reviewer of our Indian Medical and Pediatric Oncology Journal, South Asia Oncology Journal, and Curious Journal of Medical Science. He is also Assistant Professor of Medical Oncology in Government Cancer Hospital, Chhatrapati Sambhaji Nagar. He has more than 10 international research papers and publications. He is the first qualified DM in medical oncology in Marathwada and Central Maharashtra. It's my pleasure to invite Dr. Anup Toshniwal to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Anup Toshniwal.
Thank you, sir. Thank you for giving this opportunity to speak here. I thank specifically MD Agarwal, sir, for inviting me despite being such a junior doctor. I just wanted to, sir, just told me to speak something upon brighter future in hematology in India. To begin with, I'll just highlight the importance at individual level. First of all, as we know, India is the highest population in world, and we will be going through a demographic shift in next 2 to 3 decades. We will be having rapid aging of population, and with aging of population, we'll have a number of hematological issues. We already have shortage of hemato-oncologists, transplant physicians in our country. So at individual level, not only it will give us financial security, but also there are a lot of research possibility in this field as we are at cutting edge of medicine. The number of drugs, the number of investigation which are happening in oncology and hematology is beyond comparison with any other branch. It also, we all know the job satisfaction we when we get when after transplant there is increase in number of WBCs and platelets that when there is engraftment. We also know what joy we feel when a CMA responds to a TKIs. Now, going beyond individual to society level, we need hemato-oncologists and hematologists to come forward if we want to become Atmanirbhar in this field. We are already having a lot of shortage. We need to have research as we know that we cannot continue to import drugs and treatments from West. Just to give a research example, like CAR T cell was not available and it's very costly and financially unviable for most of our patients. There was a recent collaboration between TMH and IIT Mumbai, and that has significantly brought down the cost. Also, we need a lot of research and development of CAR Ts for other diseases as well. And also, we need gamma delta T cell therapies, cell receptor therapies in solid tumor as well. And there might be collaboration for same between a hematologist and a medical oncologist. Also, we need to develop institute of excellence in our country, so as we should not blindly follow the guidelines which are formed in the West. Actually, these are guidelines made for West by their own data. We need our own data by us for our own people and our own guidelines. So we need eventually to become Atmanirbhar, not also Atmanirbhar. We should be able to lead the global South, and we should become a Vishwa Guru in hemato-oncology as our Prime Minister and our government aims to be in other field. Thank you. These are my 2 cents on hemato-oncology. And I also want to just highlight for a 1 minute role of MD Agarwal sir in hematology practice in India. He has been a source of inspiration and guiding light for all of us. As we know, there is no other parallel example to quote such academic meets happening in any other field every week from international expert guiding us in this field. And also, sir was instrumental in developing and maintaining the only hematology academic department that is in KM Hospital, Mumbai. We have only 2 seats of DM hematology in entire Maharashtra, and sir was one of the major source of help for that department for maintaining that department. I again thank sir for giving this opportunity to speak 2 to 3 minutes for this webinar, and I request sir only to inaugurate, and I thank him again.
Thank you, Dr. Anup, for that wonderful, kind words of wisdom. It means a lot to us, and thank you for accepting our invitation as our chief guest. Thanks a lot. I'll now share the screen again. So now it's time to introduce our guest speaker for the day. We have with us Professor Dr. Philippe Moreau from France. Professor Dr. Philippe Moreau is director of the SIRIC Iliad, professor and head the department, hematology department, University Hospital of Nantes, France. He is also the head of the translational research program in hematology and oncology at the University Hospital of Nantes, France. He has over 20 years experience in clinical hematology and has led many pivotal clinical studies. His interests are focused on multiple myeloma and his treatment with high-dose therapy and novel agents, including cell therapies. He has been the chairman of the Intergroup Francophone du Myelome, that is IFM, since 2020 and vice president of the International Myeloma Society, IMS, since 2019. He has been a member of the steering committee of the International Myeloma Working Group, IMWG, since 2013. He has served as a principal investigator for many international randomized phase 3 clinical trials, including proteasome inhibitors, immunomodulator drugs, or CD38 antibodies. He also participated in the study of idacaptogene viclucil that received the FDA approval in March 2021 as the first genetically modified autologous chimeric antigen receptor CAR T cell therapy for the treatment of relapsed refractory multiple myeloma. In 2018, he received the Robert A. Kyle Lifetime Achievement Award. He is a member of the Integrative Oncogenomics of the Pathogenesis and Progression of Multiple Myeloma team of CRCNA, directed by Stephen Minuel. He is very frequently invited speaker at international hematologic oncologic meetings. He has authored or co-authored more than 400 peer-reviewed articles that have appeared in high impact factor journals including NEJM, JCO, Lancet, Lancet Oncology, and Blood. He is also the member editorial board of JCO, Blood and Cancer Journal. Today he is with us and is going to lecture us on treatment of relapsed refractory multiple myeloma. I stop over here. Over to you, Dr. Philip Moro, sir.
Good morning, and thank you for your invitation. Are you able to see my screen?
Yes, sir. If you can make it full screen mode, sir.
Yeah, it is.
Perfect.
Okay, thank you so much. And thank you for this, for this invitation to speak about treatment of relapse and refractory multiple myeloma. You can see here my disclosures. And in fact, when we are going to select a treatment at the time of the relapse, we have many factors that are going to help us in selecting the best option for the patients. Of course, at the time of the first relapse, for example, we are going to adapt the treatment according to the frontline therapy, the duration of the first response. Do we have a patient that is totally refractory to the frontline, or do we have a long treatment-free interval between the first line treatment and the time of the first relapse? What is going to be the potential efficacy of our treatment combinations? What is the expected PFS, OS? Disease characteristics is of importance. Do we have an aggressive relapse or only a biochemical relapse? Do we have a clonal evolution? If we are able to look at the cytogenetics at the time of the progression, that can be different from the genomics assessed at the time of the diagnosis. For example, a 17p deletion that was not existing at the time of the diagnosis. Obviously, patients' characteristics are important, comorbidities, especially age, and we have also to be on the safe side for the patients. The convenience is important. Are we going to use oral combinations, or what is the patient's choice as well? And we have really clearly to explain what are the different possibilities, and indeed, and that's very important, not only in your country, but in Europe as well, cost, access, reimbursement are going to influence this choice. So for the treatment of relapsed myeloma, in many countries, we are currently following the recommendations from the International Myeloma Working Group. And you know that we have a lot of phase 3 studies that looked at progression-free survival as the primary endpoint to try to control the disease at the time of the relapse. We have some combinations that are based on lenalidomide index with doublet versus triplet combos. We have also proteasome inhibitors as a backbone, either with VD or with KD. And we also have studies looking at Bondex as a backbone versus triplet combinations. And I mentioned here the name of all these phase 3 studies leading to the official approval of new combinations. And all studies, almost all of them, met their primary endpoint of PFS. And I listed here the hazard ratio in favor of the best combination. But we also have some data with overall survival benefit, and I listed here the OS benefit in green in, for example, the Pollux study or the Endeavor study, the Castor study, and so on. So as you see here, we have almost 15 studies, and the choice may be difficult, the optimal choice may be difficult for one specific patient. So indeed, at the time of the first relapse, we are considering that we are selecting the best option according to refractoriness, yes or no, to lenalidomide at the time of this first relapse. Many patients are receiving frontline lenalidomide until progression. For example, after autologous stem cell transplantation as a maintenance, or VRD in elderly patients, followed by Lendex until progression. So we have a significant number of patients that are going to progress on lenalidomide. They are len refractory. And in this setting, what is the best option? We have a lot of studies, but we are considering that 3 options are the best, the preferred ones: POMVD, KD-DARA, or KD-isatuximab. In fact, when patients are len refractory, you can challenge them with a proteasome inhibitor. And we know, for example, that Endeavor looked at KD versus VD, a head-to-head comparison, showing that KD, Carfildex, is better than VD, in fact. But when you are looking at the subgroup of patients, first relapse, len refractory, in fact, KD is not optimal. You see the median PFS in len refractory patients is 8.6 months only versus 6.6 for VD. So KD suboptimal. What about VD plus daratumumab? And you know that this combination was compared with bortezomib dex alone in the Castor study, and VD-DARA was associated with a better progression-free survival for the whole patient population. But when we are focusing again, same story, on lenalidomide refractory patients enrolled into Castor, a sub-analysis, in fact, DVD is associated with 7.8 median progression-free survival versus 5 for VD. So KD suboptimal, DVD suboptimal as well. What about POMVD? That was tested in the Optimism study prospectively, a prospective comparison of VD alone versus VD plus pomalidomide in relapse and refractory patients. All patients, according to inclusion criteria, were previously exposed to lenalidomide in this study. Primary endpoint PFS, and if you are comparing the whole patient population, the median PFS is 11.2 months versus 7 with VD alone in favor of the triplet combination. But let's do the same approach. Let's focus on first relapse, len refractory patients enrolled into Optimism. And you immediately see that the median PFS 18 months with POMVD versus 9.5 with VD alone. So POMVD can propose a long, quite long PFS in len refractory patients at the time of the first relapse. So that's one good choice, let's say. And we also have Carfildex, suboptimal as I mentioned, that was prospectively compared with KD plus daratumumab in the Candor study. And the patient population showed that 1/3 of the patients enrolled into this large phase 3 prospective study, 1/3 of them at the bottom of the slides were len refractory. And when we are looking at progression-free survival, there is a strong benefit in favor of the triplet combination KD-DARA for patients lenalidomide refractory, yes, with a hazard ratio of 0.46. And this is the PFS for the whole group of patients. You see that in red, the triplet combination is doing much better as compared with KD alone, hazard ratio 0.6. And when looking at the subgroup of patients lenalidomide refractory, the triplet is also very, very good. So when we look at the IKEMA study, IKEMA did compare prospectively KD versus KD plus isatuximab, so the second CD38 antibody, exactly the same study design, same control arm as the CANDOR study, progression-free survival as the primary endpoint, and again, exactly the same patient population, 1/3 were lenalidomide refractory. And the results are very superposable to that was achieved into the CANDOR study. KD alone, 19-month PFS. The addition of isatuximab is highly increasing the duration of response and PFS. 36 months almost, and the hazard ratio is the same as the CANDOR study, 0.6. And this is true for the subgroup of patients lenalidomide refractory. The progression-free survival is also improved with the triplet combination and a long PFS. And now with the long follow-up, we have also a trend for a better overall survival. So we can say that first relapse, len refractory, if you have access to KD-DARA, KD isatuximab, or POMVD, those options are the best ones. But now we have a new population of patients that is treated in our centers. We are using in Europe, in some centers, in some countries, len, dex plus daratumumab upfront in elderly patients, transplant ineligible, based on the MAIA study. And those patients are going to progress after a long PFS. The median PFS is 5 years in MAIA. They are going to progress, and those patients are not only refractory to len, but they are also refractory to a CD38 antibody. So how are we going to treat those patients refractory to two classes of agents, len and CD38? So the logical choice is to use a proteasome inhibitor in this setting, and we can use a PI-based combination, either with VD as a backbone or KD, and we can add on top of VD or KD pomalidomide, cyclophosphamide, that can be useful. But we have to keep in mind that those patients are elderly or very elderly, and not all of them are able to receive carfilzomib, for example, because of cardiac comorbidities. The second option is to use a POM-based combination, and we can use POM-dex plus bortezomib, the PVD combination, and we discussed already about this triplet combination, or a very simple and convenient combination is to add on top of POM-dex cyclophosphamide with the PCD combination. That is an all-oral triplet combination that is very convenient and quite active in this setting. And at ASH last year, we heard about a very interesting phase 3 randomized trial comparing POM-dex versus POM-dex plus cyclophosphamide. This is the only study available comparing prospectively PD versus PCD. And our colleagues from the ASEAN group showed nicely that with 3 drugs, you are immediately improving the progression-free survival from 6 to 11 months with the addition of cyclophosphamide, 50 milligrams every other day, or 300 milligrams oral once weekly. But we still have a lot of patients at the time of the first relapse that are not refractory to lenalidomide. Those patients are either lenalidomide naive, they never received len upfront, they were treated with proteasome inhibitors, VD, VCD, or they were lenalidomide sensitive. They did receive lenalidomide, but the treatment was stopped and they are progressing. At the time of the progression, they are not refractory to len. So for those patients, first relapse, not refractory to len, we are considering that 2 options are really the best ones, DRD or KRD. We know that we have combined Lendex with different drugs, carfilzomib, KRD in the Aspire study, Lendex ELO in Eloquent, Lendex ixazomib in Tourmaline, or Lendex daratumumab in the Pollux study. And this is the design of Pollux, Lendex versus DRD in patients with relapsed multiple myeloma, 1 to 3 prior line of treatment, not only first relapse for sure, and the primary endpoint was PFS. And when focusing on patients with only 1 prior line of treatment, first relapse, you see the huge impact of DRD. The addition of daratumumab is improving significantly progression-free survival. The median is not reached after 4 years in relapse when you are adding daratumumab to len and dex. All those patients were len sensitive or len naive. And if you are focusing on patients len sensitive with a prior lenalidomide exposure, DRD is also very, very effective as compared with Lendex alone, with a median PFS above 3 years. We know as well that DRD is able to improve versus Lendex on the outcome of patients with high-risk cytogenetics. But nevertheless, if you are comparing DRD standard risk versus DRD high-risk patients, there is a huge difference, and the median PFS for DRD standard risk, 52 months. Median for high risk with DRD, 27 months. So daratumumab is not able to overcome, in fact, unfortunately, the poor prognosis of poor cytogenetics. And we know as well, with a long follow-up, that there is also an overall survival benefit that was reported 1 year ago with DRD versus Lendex. And obviously, that's very important for the patients. And the second combination that can be proposed if you don't have access to daratumumab is KRD, that was prospectively compared to Lendex in the Aspire study. 800 patients were randomized in the relapse setting to Lendex continuously versus KRD. And again, same story, PFS benefit in favor of the triplet combination. The hazard ratio is 0.7, median PFS 26 months. So that's really less as compared with DRD. And there is also, with a long follow-up now, an overall survival benefit that is statistically significant in favor of the triplet combination. So at the time of the second relapse or higher relapse, in fact, what can we use? We can use Carfil as the backbone, and we discuss about the Candor KD daratumumab or the IKEMA KD isatuximab comparison, the trials, and KD Dara, KD isatuximab is better than KD alone. So Carfil Dex can be used in this setting with the addition of a CD38 antibody in patients that are not refractory to CD38 antibodies or never exposed to a CD38 antibody. But we can also use Pomdex as a backbone at the time of the second relapse. And the first approval of Pomdex a long time ago was Pomdex active in patients with at least 2 prior lines of treatment. And we can add as well, on top of Pomdex, a CD38 antibody, either isatuximab in the ICARIA study or daratumumab in the Apollo study. So this is the study design of ICARIA. All patients relapse multiple myeloma, at least 2 prior lines of treatment, so quite advanced in the course of their disease, and PD continuously was compared to PD plus isatuximab with PFS as a primary endpoint. You see that the majority of the patients, almost 90% of the patients, were lenalidomide refractory, and 70% of the patients were IMiD and PI refractory, double class refractory. And ISA-PD is associated with a significant PFS benefit with a hazard ratio of 0.6, so that's a 40% reduction in the risk of death or progression, 11.5 versus 6.5. And also with a very long follow-up, we have now a trend for a better overall survival in favor of isatuximab PD. Apollo, the study design is very, very similar, mostly patients with at least 2 lines of treatment, relapsed multiple myeloma, PD versus PD plus daratumumab subQ, PFS as a primary endpoint. And again, the results are very, very similar to that was achieved into ICARIA, median PFS 12 versus 7 months in favor of the triplet combination. And again, the study was updated with a very long follow-up last year, and you see that there is a trend, only a trend, for a better overall survival. So definitely triplet are commonly used, in fact, in relapsed multiple myeloma, as you see. And the addition of a CD38 antibody is always improving on the outcome of our patients. Sorry. But what will be the future, in fact, for those patients with quite an early relapse, 1 to 3 prior of treatment? We have heard very recently of the CARTITUDE-4 study, a prospective comparison in the relapse setting of conventional treatments versus cilta-cel. And into this CARTITUDE-4 trial, all patients had from 1 to 3 prior lines of treatment, and all of them were lenalidomide refractory. And patients were randomized to what we are calling standard of care, POM-VD or DARA-PD, versus cilta-cel, the CAR-T targeting BCMA, one shot, in fact. And the patient population was quite advanced, with a median number of prior lines of 2. And you see that the median age was 60 years, and the progression-free survival is in favor of the cilta-cel CAR-T cell therapy. The median at the time of the first report was not reached, versus 12 months in len refractory patients, and the vast majority of those patients were treated with Pomdex daratumumab. You see the big difference in favor of the CAR-T cell therapy. And all subgroups of patients are benefiting from cilta-cel versus standard of care. And when you are treating those patients at the time of the first relapse with cilta-cel versus 2 or 3 prior line of treatment, you see that the outcome is even better. So this is really changing, that will change in the future, probably our way of treating patients in the relapse setting for len refractory patients, CAR-T cell therapy that is currently not yet available in many countries. I believe that only the US and Germany only 2 countries now are able to use cilta-cel. In my country, we cannot use because we don't have yet access to this CAR T, but nevertheless, that's one option for the future. And 3 weeks ago, during the International Myeloma Workshop, we have heard about the update analysis of CARTITUDE-4, showing that cilta-cel, with now a long follow-up of 3 years, is definitely much better than standard of care for lead refractory patients. And importantly, there is now an overall survival benefit that is quite significant with a hazard ratio of 0.55. In fact, 45% reduction in the risk of death with cilta-cel. So this is really changing totally the view of future treatments, in fact, for myeloma relapse patients. And we also heard about a new combination with belantamab mafodotin, belamaf, an antibody drug conjugate that is targeting BCMA that was combined, in fact, with VD in the DREAM7 study. DARA VD was compared prospectively with Bela VD, and you see the good, very good median PFS of 3 years for those patients treated with the triplet combination. You know that belamaf, the development was stopped, in fact, after that the FDA and EMA mentioned that the drug could not be used in very, very, very advanced patients. But those studies, DREAM7 and DREAM8, were still ongoing. And now we have those results, and maybe next year or by the end of this year, belamaf will be reapproved in combination with bortezomib and dex, or we have the DREAM8 study when belamaf was combined with pomdex and prospectively compared a triplet versus a triplet, pom-VD, a good triplet combination in the relapse setting, versus bela-PD, and you see again that belamaf is associated with a very, very good PFS and a very good hazard ratio of 0.5. The issue with this drug is the ocular toxicity that is remaining a big concern, because many, many patients are really complaining about this blur vision and this ocular toxicity. So maybe we have to adapt the dose of belamaf and to try to reduce the dose. The results are good in terms of efficacy, but from a safety point of view, that's not ideal, I would say, for our patients. So we need to wait for a new approval of Bela-VD and Bela-PD. And what is happening to our patients that are triple class refractory? Refractory to IMiDs, to PIs, and to CD38 antibody. What is the optimal choice? The optimal choice is probably to use an anti-BCMA strategy. And you know that we looked at the outcome of those patients in Europe very recently treated in our centers, and all of them were triple class refractory but did not receive any immunotherapy. Those patients were prospectively, systematically evaluated in the locomotion non-interventional multinational study. And in fact, those patients, triple class refractory, were treated with 92 different regimens for 250 patients. So it means that there is really no standard of care when your patient is triple class refractory. And we tested a lot of different combinations, 92 indeed, and the overall response rate is only 30%. The median PFS is 5 months, and the overall survival is 1 year. So when you are developing now a new treatment, a new immunotherapy, for example, this is the benchmark in triple class refractory patients. You should reach at least a median PFS of 5 months, and you have to improve on the overall survival of 1 year. And why BCMA is the best choice? Because BCMA was discovered, as you know, a long, long time ago, 32 years ago. and our colleagues from Paris looked at the expression of BCMA, and they immediately noted that BCMA was only exposed on plasma cells with absolutely no expression on the heart, on the liver, on the kidney. So this target is of interest because all the myeloma cells are expressing BCMA, and immediately those guys mentioned we should try to find drugs targeting BCMA because there is no expression on normal tissues and you will not have any significant toxicity probably, and you're going to kill the myeloma cells. But importantly, we know that BCMA is also and always expressed on the normal plasma cells. It is important for the survival of long-lived plasma cells. So when we are going to target BCMA, we are going to kill the myeloma cells, but also normal plasma cells, and we are going to induce a severe hypogammaglobulinemia systematically. So in order to target BCMA, we can use either CAR T-cell therapy or bispecific antibody. And you know that the first CAR T that was approved is ide-cel, based on this paper, the KarMMa-2 study in the New England 3 years ago, and at the optimal dose of 450 millions of CAR Ts, the response rate is 82%, so very high response rate. The median PFS at the optimal dose is 1 year, and the overall survival, median OS, is 2 years, in fact, with ide-cel. So based on this study, ide-cel was approved in triple-class refractory patients. But 1 year later, we've heard about the CARTITUDE-1 study with the second-in-class CAR T targeting BCMA, cilta-cel, with a different construct, in fact, and the results are really outstanding with this CAR T. The response rate is 98%, and the responses are very, very quick. The median time to first response is 1 month. And the study was updated with a long follow-up, and the median PFS is 3 years. That's 1 year with ide-cel and 3 years with cilta-cel. And look at this very, very good overall survival in triple-class refractory patients. The median OS is not reached at 4 years. So incredible good results. The issue with cilta-cel is, again, first the access and second the cost, or first the cost and second the access. We still don't have access to cilta-cel in my country. But there are some subgroups of patients that are benefiting less from CAR T-cell therapy. Patients with an ISS3, patients with poor cytogenetics, patients with baseline extramedullary disease at the time of the treatment. So we have to keep this in mind, that not all patients are benefiting the same for CAR T-cell therapy. And this is the subgroup analysis of the cilta-cel CARTITUDE-1 phase 2 study. You see that patients with ISS3, poor cytogenetics, EMD, are having a shorter PFS as compared with the others. And we also have to keep in mind that this patient population into not only CARTITUDE-1, but also KarMMa-2 for ide-cel is a highly selected patient population with an ECOG of 0 or 1, with quite a good renal function. So not all patients in routine practice, when they are triple-class refractory, are as fit as the patient population of CARTITUDE-1 or KarMMa-2. Of course, we can have indirect comparison looking at cilta-cel in blue versus locomotion, the prospective cohort of patients triple-class refractory who did not receive any immunotherapy in red. And you see that there is a big difference in terms of PFS and OS, showing that obviously, if possible, those patients can receive CAR T-cell therapy. And this is the comparison of cilta-cel in green versus ide-cel in blue. That's not a phase 3 study. That's the comparison, a matched, adjusted, indirect comparison of the two phase 2 studies, KarMMa-2 and CARTITUDE-1. And in fact, cilta-cel seems to be the best CAR-T available. We also have now real-life data that were recently reported and published a few days ago with cilta-cel in the real-life setting outside CARTITUDE-1. And in fact, in the US, many patients would have been ineligible for the CARTITUDE-1 studies because of ECOG, because of cytopenias, because of a prior treatment with an anti-BCMA. So immediately when we have access to new agents, we are using those agents in more advanced patients, and the outcome, in fact, is quite interesting. The overall response rate is quite similar to that of the pivotal study for the approval, CARTITUDE-1. But the real-world PFS, the real-world OS is less as compared with the paper published in the GCO, because patients are really more advanced, in fact. And we also have real-life data for ide-cel, as published last year in the GCO by our US colleagues. More than 150 patients in the real life did receive ide-cel. And you see that the exclusion criteria for KarMMa-2 were met in 75% of the patients. So the patient population was much more advanced as compared with the KarMMa-2 patient population. And again, same story, the response rate, 84%, exactly the same as KarMMa-2, but the median PFS is shorter and the median overall survival is also shorter, showing that this patient population was very advanced. We also have a very, very large real-life data coming from the all US country. More than 800 patients were treated, and the survival outcomes are quite good. Let's say, confirming that CAR-T cell therapy is very effective, in fact, in patients that are triple-class refractory. But ide-cel, cilta-cel is not available in many, many countries. In fact, very few countries have access to this anti-BCMA strategy. So we can also use anti-BCMA bispecific antibodies when patients are triple-class refractory. There is a number of BCMA bispecific antibodies in development, but only two of them are approved currently. Teclistamab, based on the MajesTEC-1 trial, and elranatamab, based on the magnetism-free study. Tecli was approved based on MajesTEC, published in 2022, a phase 2, a large phase 2, published in the New England. So this is the way the bispecific antibodies are acting. You know that those bispecific antibodies are targeting BCMA on the myeloma cells and targeting CD3 on the T cell, and they are redirecting, in fact, the T cells to BCMA expressing myeloma cells, and they are inducing the apoptosis of the myeloma cells. Into MajesTEC, teclistamab was tested and was used during the first week. All patients were in the hospital during the first week with 2 step-up doses. And we have increased the dose with a very low dose at the time of the first administration, sub-Q, 60 microgram per kg. And then the second dose, 2 days later, times 5 from 60 to 300 microgram per kg. And then the third dose, the full dose, times 5 again, from 300 microgram per kg to 1.5 milligram per kg sub-Q. So in 2 doses, you are increasing quite rapidly to reach the full dose of 1.5 in order to reduce the toxicity, the initial toxicity, the cytokine release syndrome. And then sub-Q weekly in the outpatient setting during the first 6 months. And after 6 months, you can switch to an administration every 2 weeks. This is the patient population. We have a quite significant number of patients that were older than 75 years of age. So it is feasible. Teclistamab is feasible in very elderly patients and almost all patients who are triple class refractory. The overall response rate, 63%. So 2/3 of your patients are going to respond to teclistamab, and the responses again are very quick. The median time to first response is 1 month only. And some subgroups of patients are benefiting less. In fact, again, same story, 60% of response, with the exception of patients with ISS3, patients with extramedullary disease. The response rate is only 35-40%. The median PFS, 11 months. And what is very important for me is the duration of response. You know that 2/3 of your patients are going to respond, and you know this very quickly after 1 to 2 months, in fact. And then if the patient is responding, the patient and the family will ask you immediately, but how long will be my response? So in median, it will be 2 years, 21.6 months. And that's a very important information. 2/3 of the patients are responding, median duration of response, 2 years. And the median overall survival for the whole patient population was 2 years as well. So what about toxicity? And I mentioned CRS. CRS grade 1 and 2 for the majority of the patients. 70% of the patients are experiencing any CRS, but only 1% of grade 3. So very few grade 3, almost no grade 3, only grade 1 or 2, and grade 1 or 2 is really manageable in your routine practice. The CRS is very predictable. The time to onset is 2 days. The median duration is 2 days. And you know that for grade 1 CRS, you can use, or grade 2, grade 1, long prolonged grade 1 or grade 2, 1 single dose of tocilizumab, and you are going to control very easily the CRS. So we have a lot of guidelines now, or recommendations for the management of CRS. Grade 1, that's fever only. Grade 2, that's you can use immediately toci, and you will control very easily the CRS. What about neurotoxicity with teclistamab and bispecific antibodies? Almost no neurotoxicity. ICANS, very, very few, 3% only. And we also have some guidelines, indicating that you can use high-dose dex alone during a very short period of time, 2 days, and you will control easily this toxicity with bispecific antibodies. The most important toxicity is infection, in fact, and in Majestic 1, since you are killing the normal plasma cells, you are inducing for all your patients, a deep hypogammaglobulinemia, less than 4 grams per liter after the end of the first month of treatment. So infections were observed in almost roughly 50% grade 3 or 4. So that's really an issue, for your patients. So you have to use a systematic IVIG administration. And you see here on this slide that the rate of infection is decreased, in fact, after 1 year when we are switching from every week to every 2 weeks the administration of teclistamab. And this picture is showing that for those patients that are not receiving IVIG, in fact, replacement, the rate of severe infection is increasing over time. But for those patients who are systematically receiving a monthly IVIG replacement, the rate of infection is remaining low and stable over time. And the second in class is elranatamab, that is also targeting BCMA, and this development of ELRA that is now approved by FDA and EMA is based on the magnetism 3 study and the cohort 1, a large phase 2 trial. In cohort A, patients were never exposed previously to any BCMA treatment, and all of them were triple-class refractory. The schedule of administration, 2 step-up doses as well during the first week, in fact, with a fixed dose. The difference between Tecli and ELRA is that Tecli, we are adapting the dose according to the body weight, and for ELRA, that's a fixed dose to 32 milligrams, and then the full dose of 76 weekly during the first 6 months, and then systematically every 2 weeks after month number 6 in the outpatient setting. So this is the patient population, and you see that 97% of the patients were triple-class refractory. The response rate is very similar to that of teclistamab, roughly the same, 61% in magnetism-free, 63% in Majestec, and same story for patients with ISS-free, patients with extramedullary disease, patients penta-refractory. The response rate is lower, close to 30% only. So not all subgroups of patients are benefiting the same from ELRA. The median PFS is quite, well, I would say slightly longer as compared with teclistamab, 17 months, but the median overall survival is exactly the same as Tecli. So I would say that the two agents are very similar in terms of efficacy. And some subgroups of patients are really no benefiting, unfortunately, for bispecific antibodies. And if you are looking at patients with an ISS3 plus high-risk cytogenetics or ISS3 plus EMD, the overall response rate is 0%. So you have to have this picture in mind when you are going to propose the treatment to some of your patients. The toxicity is really identical to that of teclistamab, no grade 3 CRS, infection is an issue, exactly the same. So we need to use IVIG according to these recommendations from the International Myeloma Working Group. And to close, I will very briefly speak about those patients that are quad refractory to IMiD, PI, CD38, and BCMA, either bispecific antibodies or CAR T-cell therapy. What is the outcome? And this is the experience in my center of patients that were quad refractory, including the refractoriness of BCMA. The PFS, 4 months, the OS, 6 months. So this is really now the unmet need. And you see on the right-hand side of the slide that there is a very small group of patients in red with a better outcome. And those patients were treated with a bispecific antibody targeting GPRC5D. In fact, when patients are quad refractory, you can use new agents, clinical studies, or new bispecific antibodies, and there is only one that is currently approved, that is talquetamab. 2 are in development, talquetamab approved based on Monumental 1, and forimtamig currently in development. GPRC5D is always expressed on the myeloma cells, but is also expressed on the skin, on the nails, and on the central region of the tongue. That will explain the significant toxicity of talquetamab. Talquetamab was developed in the Monumental 1 study, and this is a bispecific antibody targeting CD3 and targeting GPRC5D, exactly the same mechanism of action as compared with teclistamab. And in Monumental, we have tested 2 large cohorts of patients, 2 different doses, 0.4 and 0.8 milligram per kg every 2 weeks. And 0.8 is the current dose that is approved for the routine practice, in fact. And you see that the response rate is very, very good with talquetamab, 74%, 70% of response in patients triple class refractory. And we also have a small cohort of patients that were previously treated with an anti-BCMA or a T-cell redirecting treatment. And for those patients, in fact, the response rate is 64%. So talquetamab is able to rescue patients failing BCMA CAR-T, for example, or BCMA bispecific antibodies. And you see that with the short follow-up, the duration of response is quite good, and the median progression-free survival at the dose of 0.8 every 2 weeks is 14 months. What about the toxicity? In fact, we have this skin-related adverse event, this dysgeusia, and this dry mouth that is impacting, in fact, the quality of life of the patients. We cannot do anything, in fact, to reduce this toxicity, only to reduce the dose from 0.8 to 0.4 and to delay the dose every 2 weeks, from every 2 weeks to every month. And the patients are recovering from this skin and oral toxicity, and then you can restart the treatment and you are having the good efficacy of your treatment. So to conclude, I would say that in very, very advanced patients, bispecific antibodies are, to my opinion, one of the best options with a good PFS. You can treat your patient in the outpatient clinics, in community hospitals, and you know that there is a big development of those agents at earlier lines of treatment. And I thank you for your very kind attention today.
Thank you, sir, for that fantastic and lovely lecture as always. It was quite eye-opening for us what a data you created for this relapsed refractory myeloma. Thank you, sir. Fantastic lecture, superb lecture. And now, so should we start with the discussion or the case presentation first?
Dr. Philip, should we present the cases or have discussion? How much time more do you have?
Yes. In fact, I can stay, something like not more than 10 minutes with you. I already have another call, but I can wait a little bit, but not more than 10 minutes. Really sorry about this.
We can have questions and then we can discuss cases amongst ourselves. Yeah.
Sure. So I request all our discussants to please put the raise hand signs so that we can start our question session with Dr. Philip Moro.
Yeah. Can I ask a question?
Yes, sir. Please go ahead.
How do you sequence between bispecifics and the CAR-T?
Yeah, that's a very good question. In fact, currently we have very, very few data with few patients, but what we are thinking is that if you can have access to CAR-T, you should use CAR-T first and one and done with a quite good treatment-free interval. And at the time of the progression, you can rescue patients with bispecific antibodies because the loss of BCMA is uncommon, and probably you can re-challenge your patient with a bispecific antibody. If you are starting with the bispecific antibody first, then continuously until progression, the CAR-T is really less effective when there is a progression on treatment with bispecific antibodies.
There's one more question. Should we give prophylactic IV gamma globulin right from the beginning to all the patients receiving anti-BCMA treatment?
I don't think that we need systematically to use with CAR T-cell therapy because hypogammaglobulinemia is occurring during a short period of time, from 3 to 6 months, 3 months mostly. But for bispecific antibodies, yes, if you're looking at the IgG, normal IgG level, in fact, there is really a drop, after month number 1, always less than 4 grams per liter. So in my routine practice, I'm using systematically IVIG after the end of the first month. And unfortunately, this is adding to the cost, as you can imagine. But this is something that I'm doing. And then we are really dramatically decreasing the rate of severe infection.
Thank you.
Thank you, sir. Sir, there's one question from the audience. Yes, Dr. Ravrit wants to know that will all RISS1 stage 1 patients relapse eventually?
I did not hear your question. Please, can you repeat?
Yeah.
This question from Dr. Ravrit. Will all RISS stage 1 patients will eventually relapse?
Oh, yes. Well, unfortunately, when we are speaking about curing myeloma patients, I believe that very, very few currently are cured. That's probably something like 20%, 30% maximum with the quadruplet combination and autologous stem cell transplantation. So that's very few patients, and those patients have a standard risk and not a high risk. So in the relapse setting, we are never curing any patient, even with CAR T. Well, it seems that with cilta-cel, maybe we have a sort of plateau, but I'm not sure that we are curing anyone, in the relapse setting, I mean, unfortunately.
Thank you, sir. Dr. Upendra Sharma, your question, please.
Thank you. Thank you for that question. So, for teclistamab, do you do IgG levels and then you administer prophylactic intravenous immunoglobulin according to those levels, or you give irrespective of those levels to all patient IVIG until how long?
Yes, in fact, that's a very, very good question. If you are checking your IgG level systematically, you will see that after the end of the first month, for all patients, IgG is less than 4 grams. So you can do, and you can replace, because maybe that can be more easy for you. There are very, very few cases for whom the IgG level will be above 4. So in my experience, almost all of them are less than 4. So I'm using systematically IgG. And how long? This is also a very, very important question, because after month number 6, we are reducing, the dose schedule, and instead of weekly, we are switching to every 2 weeks. Then maybe in every 2 weeks, you can use IVIG every 2 months instead of monthly, and the infection rate will remain very low. But the issue with bispecific antibodies is that we are proposing treatment until progression, and probably that's a mistake. We should probably use 1 year or 11 or 18 months and then stop the treatment, because, well, the patient are fed up, of going back and back and back again to the hospital to receive their treatment, but not sure that there is a strong benefit, of using until progression. Maybe we could use a fixed duration, 1 year, 1 year and a half, then stop, and maybe we could re-challenge with bispecific at the time of the new progression. So there are some academic studies ongoing to compare treatment until progression versus fixed duration.
One short question again, sir. So, very role of bispecific antibodies in extramedullary disease and CNS disease.
Well, with extramedullary disease, the efficacy of bispecific antibody is really reduced. The response rate is only 30%, and those responses are really shorter. So the PFS is not good, response rate is not good. So, and that's also true for CAR T-cell therapy. The same outcome, the worst outcome for EMD or CNS involvement. So I'm not recommending, and we have some studies ongoing, in fact, with combinations of talquetamab and teclistamab, for example, in patients with EMD, and we have heard the update analysis of these studies combining bispecific antibodies, and maybe that's the best way, of controlling this disease. That is really the worst case scenario.
Thank you, sir.
Thank you, Dr. Upendra Sharma. Sir, we'll take one question from the audience. What is the role of venetoclax in those without translocation 11-14 for triple or penta refractory?
Venetoclax, when you are not 11-14, well, there is really no role. Maybe, there are very, 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 very small group of patients with high BCL2 without 11-14. But I would focus, venetoclax is not approved, yet, but many of us are using venetoclax because that's a drug that is available for CLL, etc. So we are using in very advanced patients with 11-14 only, and I will focus only for this group of patients.
Thank you, sir. Dr. Yogalakshmi, your question, please.
Thank you for the informative lecture, sir. Actually, when we are using teclistamab like BCMA bispecific antibodies in relapsed setting, when the patient becomes refractory to this, is BCMA-based CAR-Ts useful in these patients?
So this is an important point, because we need to understand, what is the refractoriness of our patients to BCMA strategies and what is the mechanism of this refractoriness. We know that some patients are losing the target, losing BCMA, but that's only something like 5 to 10% of the patients only. So BCMA loss is uncommon. But if you have a progression on teclistamab, patients are not rescued by elranatamab and vice versa. There are some data coming from the group of Calgary, Nizar Balis, showing that we have the target is not exactly the same epitope, on BCMA, etc. So in very few cases, maybe alnuctamab, another bispecific antibody, can rescue teclistamab or ELRA failures, but that's only, ex vivo data. In the routine practice, well, if you are failing tecli, you don't use ELRA and vice versa. And if you are not losing the target, if BCMA is still expressed, CAR T-cell therapy can be of interest, but the efficacy is really reduced. So maybe if you want to use something, you should change the target and use an anti-GPRC5D, such as talquetamab, for example.
Thank you, sir.
Thank you, Dr. Yogalakshmi. Dr. Mallikarjun, your question.
No, Professor Philip, very well presented, really. So I think lot of our questions have been answered. My simple question is: we had a patient who had triple class exposed pentarefractory. We initiated him on teclistamab, and after step-up dose and after 2 to 3 weekly doses, the paraprotein has almost disappeared, both kappa lambda and SPP. In such patients, can we go to once in 2 weekly instead of weekly, just for the sake of cost?
Yes, definitely, that's a very important question. And when Johnson developed teclistamab, they have proposed weekly until progression. And then ELRA came, and Pfizer mentioned that we could use ELRA every 2 weeks after month 6. So Johnson said, oh, yes, we could do the same. So the optimal schedule, is not very, very clear. Based on PK and PD data, if you are achieving an early response, maybe you could switch immediately after month 2 to 3, like your patient, to every 2 weeks. That's something that is totally feasible. And you're going to reduce the cost and probably the toxicity as well in terms of infection.
Thank you so much.
Thank you, Dr. Mallikarjun. Dr. Chirag Shah, your question, please.
Take that as the last question then, Dr. Kendra.
So, if patient has not had transplant in the first line, or then say they are triple refractory, would that still be worth doing?
Oh, that's a very, very good question. Well, for me, if the patient is transplant eligible, he should receive transplant at the time of first treatment for all patients. This is how we are treating patients. But that's true that we still have some patients that are considered transplant deferred, and they are not receiving high-dose melphalan. So when they are becoming triple class refractory, first of all, you need to have a graft, and well, that's very, very difficult to be able to harvest successfully CD34 positive stem cells in a patient that is triple class refractory. That's very uncommon. So maybe the feasibility of the stem cell harvesting setting is very, very low. But if you have stem cells that were previously collected and frozen, yes, you can use, because high-dose melphalan, high-dose alkylator is very, very active. But in triple-class refractory patients, I don't know exactly what is the outcome of high-dose melphalan and autologous stem cell transplantation. We have some data for salvage high-dose in the earlier relapse setting, but for very advanced patients, we don't have any data. But I will try for sure.
Just in triple refractory, also role of oral melphalan. We all have patients where some go on for 2 years, 3 years after failure of everything. Is there a way we can choose better as to who is more likely to benefit from that?
Yes, definitely. That's something that is feasible. And I showed you the results of the locomotion study. Locomotion, that was exactly this situation, 250 patients, triple class refractory, and they were progressing, so what to use? Many of them did receive, again, alkylators such as bendamustine, cyclophosphamide, oral melphalan, and the response rate is 30%, and the duration of response is very short. So yes, indeed, you can try, but the response rate very likely will be low, and PFS will be short, unfortunately.
Thanks.
Thank you, Dr. Chilaksha. Sir, you need to go, or should we continue?
Yes. Thank you so much.
Thank you,
you
sir.
for inviting me again. Thank you.
Lecture. It was superb, and what a wonderful discussion. Thank you, sir.
Thank you.
Bye-bye.
Bye-bye. Nice day.
So now we will proceed with our case presentations. Let me share the screen again. So we have our first case presentation for early relapse by Dr. Mallikarjun Kalashetty from Bangalore. And to just give his introduction, Dr. Mallikarjun Kalashetty is consultant in clinical hematology, hemato-oncology, and BMT at Comprehensive Cancer Center, Manipal Hospital, Bangalore. And he's going to present the case on early relapse. Over to you, Dr. Mallikarjun.
Thank you, Dr. Amit. I'll quickly go through the my slides are visible. I hope I'm audible. So I think we have discussed most of the issues about this case anyway. So I'll go through this case. So this was a 55-year-old gentleman who was a lecturer. Initially came to us with fatigue, persistent bone pain, particularly lower back and pelvic area. He had recent worsening of the fatigue, and then he also had loss of appetite and other constitutional symptoms. So brief medical history, he was diagnosed with multiple myeloma about 2 years before when he had symptomatic myeloma with hypercalcemia, bone disease, and anemia. And he also had elevated paraprotein, marrow confirmed multiple myeloma. His cytogenetics put him in high risk multiple myeloma category, and he had advanced stage disease at the diagnosis. So he was treated with induction protocol of VRD, which is what we commonly use. He achieved partial remission after 4 cycles, underwent 200 milligram per square meter of melphalan conditioned autologous transplantation. And post-transplant, he achieved VGPR, but then he had flow MRD persistently positive. He was put on dual maintenance therapy, bortezomib once in 2 weeks, and lenalidomide 10 milligram every day. He was in fairly good health for about 6 to 9 months, and then started having rapidly rising, almost doubling paraprotein after 10 months of autologous transplantation. Started on second-line therapy with carfilzomib, pomalidomide, dexamethasone, had partial remission, but then progressed within 8 months with new bone disease, bone pain, and worsening anemia. This time he was treated with daratumumab-based treatment, cyclophosphamide, dexamethasone, responded initially again, but then in next 6 months he had progression of the disease with all the disease-related symptoms. So quintessentially, this gentleman who was young, had no comorbid illnesses, had worsening myeloma symptoms over 3 to 4 lines of therapy, post-autologous bone marrow transplantation, and now confirmed to have disease again. He already had high-risk cytogenetics at the diagnosis, so relapsed refractory multiple myeloma, high-risk cytogenetics, triple class exposed, perhaps pentarefractory. He still has good performance status, no comorbid illnesses. I think this is the patient that we initiated him teclistamab. I think we have discussed about him, and I stop my case presentation here. Thank you.
Thank you, Dr. Mallikarjun. What a nice case. I think teclistamab would be the way to go here. Absolutely. Yeah. This is a real refractory case. We'll go with the second case presentation now. So we have with us Dr. Siddesh Kalandri. He's going to present the case on late relapse. He's a consultant hematologist, hemato-oncologist, and stem cell transplant physician at Blood Care Hematology Clinic, Nashik. And he's going to present the case on late relapse, multiple myeloma. Over to you, Dr. Siddesh.
Thank you, Dr. Amit, for introduction. Thank you, Agarwal sir and MSG for inviting me for this case presentation.
Can you please make it in full screen mode, please?
Yeah. Okay. can see, yeah. So I'm going to present a very unusual case of late relapse of plasma cell leukemia. So it was difficult for me to accept as well, and that's why I've put in all the screenshots of records which I had. So this was a case who came presented elsewhere in Jalgaon in 2015. At that time, she was being evaluated for repeated anemia. Presenting hemoglobin was 3.8 gram, and her peripheral smear had plasma cells 16%. She had back pain at that time. M-band was 6.7 gram. Fish was not done, was not available at that time probably. And marrow had 75% plasma cells and M-band was 6.5 gram. So this was her CBC from October 2015, and wherein the pathologist has identified 16% plasma cell, and after that patient's further workup was done. Aspiration again showing plasma cell dyscrasia, and cytogenetic abnormality was not there, but though it was conventional karyotype which was done, and it was 46XX. So the diagnosis for this patient was whether this patient had plasma cell leukemia or multiple myeloma. She was managed at Charitable Hospital in Gujarat. She received 18 months of VTD. 2017 and 21 immunofixation was negative, and this is the report of 2021. CBC was normal. After COVID, she stopped follow-up, and now again in 2024 came with fracture neck femur, which was non-traumatic. HB was 4.8 gram. Calcium was 8.6, creatinine of 1.7. This is pathological fracture now. And this was the peripheral smear which we did at clinic, and it had 6% of plasma cell. So my question was, what is the longest survival seen by Agarwal sir? Like, you have a lot of experience by you in patients of plasma cell leukemia treated without transplant. What would be the contributing factor for long-term survival? Current age is 56. What would be the ideal plan for her right now? And how would you treat patient with late relapsing myeloma if this patient would have not been a case of plasma cell leukemia, just a case of multiple myeloma? And considering long-term PFS with VTD, VRD, are we going to repeat same considering poor economic status for them?
So thank you, Dr. Siddesh. I think Dr. Agarwal sir has also left, but we'll discuss among ourselves. So I will ask the first question to Dr. Mallikarjun. What is the longest survival have you seen in a patient with plasma cell leukemia?
So I kind of agree with Dr. Siddesh. We all have seen some of these patients who have circulating plasma cells upfront, and then they do reasonably well. But I would say with the availability of DARA, the survival has improved a little. However, with conventional therapy, it would be 6 to 12 months, most of them, after they fail the first line therapy.
Sir,
Yeah.
Dr.
Yes.
Anup Tosniwal here. Siddesh had told that he was not he's not expecting that kind of survival in VTD, and that's why he's attaching on the screenshots. We recently got a patient from Hyderabad for a second opinion in government cancer hospital whose plasma cell leukemia survival was almost 10 years. And that too also after VRD. VRD was the most advanced regimen available at that period of time. 2013 or 14, he had treatment with there. With the hematologist, and now he has relapsed and now planned for a transplant with daratumumab.
Great. Dr. Upendra Sharma, do you have any other answer or advice for us?
So with plasma cell leukemia, I think this is the I've not seen there's so much of survival with a patient, but for myeloma patient, I have seen patient. I have two, three patients wherein I used initially when I came to Jaipur in 2012 VRD, and those patients are doing well on VRD. They're not relapsed till now. But a few cases only. Otherwise, but for plasma cell leukemia, I've not seen a survival for so many 10 years and not seen such case.
Dr. Ashok Mishra, your comment?
So for plasma cell leukemia, I have seen 3 cases, but not survival more than 7 months to almost 1 year. So that even one patient was treated with autologous transplant, and thereafter also he had a relapse and then died. So it is very surprising that that patient survived only with VTD for so long.
True. Dr. Chirag Shah?
I don't have this kind of data for my patients, but I agree with Dr. Toshniwal that there are occasional patients, and I do remember from the practice having patients who had plasma cells in the peripheral smear, and in early, maybe 15 years ago, when we were not having more advanced treatments, and still they did uh, uh, fairly well for a few years. So I believe there must be a lot of or some heterogeneity at least, and the numbers that we quote are median survival for plasma cell leukemia, but it is possible that all of them don't behave in the same way. As per this patient's plan now, I would do fish at this point to see what changes have happened, or what is the current cytogenetic status. But if cost is an issue, then VRD or maybe even bortezomib pom-dexa can be done. Pomalidomide has significant response in multiple high-risk cytogenetic abnormalities. So, and POM and the LAM cost-wise essentially same. So that you can try. And also their creatine is not an issue. So you can give full dose pomalidomide with low GFR.
Absolutely. Dr. Upendra Shah, you want to add something in the treatment plan? At 56 years of age, now what should be done?
So our treatment plan, Dr. Satish has cut down because of the finances. So we can't think of much of for this patient. I agree with Dr. Chirag. So we can give. So VTD has been given to this patient now with creatinine of this 1.7. Pomalidomide is a good option. So lenalidomide, if has to be, then has to be dose adjusted with the creatinine clearance. Else pomalidomide is a good option. If but nowadays, for such patients in Rajasthan, where cost is an issue, if we can somehow bring this patient into remission, we have some government schemes wherein we can have autologous stem cell transplantation free of cost to these patients who are belonging to Rajasthan, having some card with Bhamasha or Chiranjeevi Yojana. So those can transplantation is a option for those patients. So we have to bring this patient into remission, and then with transplantation is a good option. In our Rajasthan, we can do this such therapy with finances are a constraint. If finances are not constraint, we have discussed much of things, and we know all this stuff.
And for example, the fish shows translocation 1114 now. Would you go for venetoclax?
So venetoclax, this patient has responded well. So I don't think so. Venetoclax is a good option when he's young patient, late relapse, used only one class of therapy. So with we have many other good options for if we are not having any say good options with high cost therapy, we can go ahead with the same drugs which patient has used. We can replace thalidomide with lenalidomide or pomalidomide. I don't think so that venetoclax is a good option for this subset of patient.
Thank you, sir. Dr. Chirag, sir, you can answer another question. How would you treat with late relapsing myeloma if this has not been a case of plasma cell leukemia?
So, I mean, in this patient, since there is a good, disease-free interval, I would still consider using bortezomib pom-dex and DARA if cost is not an issue, and followed by transplant, which again, I suppose, so even the same regimen can be used for plasma cell leukemia also. But if cost is an issue, then bortezomib pom-dex.
True. Dr. Ashok Mesham, do you have anything to add on this? Late relapse myeloma, not plasma cell leukemia now.
So in late relapse myeloma, DARA will be a good option. So this particular the previous case, one is it's mostly a primary plasma cell leukemia, but it might be some heterogeneity. Otherwise, I have seen one case of primary plasma cell leukemia, and others where when the myeloma become refractory and they leukemic conversion. So second type also they were also very bad. So in this patients, if we bring them to remission and do transplant, so that is one option is there.
Absolutely. Dr. Satish Kumar, you want to add anything?
Hi, Amit. So nothing, just wanted to, most of the things have been discussed. So I do have a case, a similar case, who is still in remission, 7 years. We had the same doubt as Dr. Siddesh mentioned, whether it is plasma cell leukemia versus multiple myeloma, but the pathologist had said, there were more than 2,000 circulating plasma cells. So we started on BRD, and I think she received, she was elderly, like 65 plus. So we gave her some 7 to 8 cycles and then maintenance for a couple of years. Fish and cytogenetics were normal. This is, I'm speaking about 2016-17. And touchwood, 7-8 years later, she's still in remission. She's not showed even biochemical relapse. So these are anecdotal cases. Even we were surprised. They went to Tata, and Tata people also said, TMH people also said, whether those plasma cells, it was over-diagnosed or is it more than 2,000. But these are standard risk by cytogenetics and fish, and she's doing good. So there will be anecdotal cases. We cannot generalize and say plasma cell leukemia, they live longer. We all know the prognosis is bad, but there are anecdotal cases where they have pulled on for several years. Coming to this patient, I completely agree with Dr. Chirag and others who whatever they have said. I would do the same thing for late relapse. Given the financial constraints, we can start with bortezomib, lenalidomide, dexa, or bortezomib, pomalidomide, dexa, and see how she does. And definitely, because the age is 56, we should consider transplant at least now, I feel.
Thank you. And if the patient is very well affordable in this scenario, late relapse, what would be your first line of therapy?
I still would go for these three things.
Very affordable.
So if you're aiming towards daratumumab, clinically, if the patient is doing good, we can get away with 3 and reserve daratumumab for the next relapse, especially if you're planning for transplant. But if she's not responding well, if the M band is not going down, I would definitely not hesitate to add daratumumab.
Thank you. Anybody else want to answer? Very affording late relapse, apart from the usual DARA, Carfil, POM, whatever we have discussed.
With good DFI, I don't know if I would jump to teclistamab. Because until we have, I think, more experience and the toxicity wise, the risk benefit ratio, because unless we have a very good plateau on the curve, I think risk benefit ratio is to be important, because we could lose patients from infection with 50% infection rate. And with India's high MDR bacteria, we have to think differently than the Western people. There's a lot of issues that we have of our own.
True, absolutely.
So for me, if this patient is affording, I will definitely go, because it is a case of plasma cell leukemia. So patient has responded initially. He is not lucky. He will not always be a lucky person. So with that, having now patient having plasma cell leukemia, should be given a best treatment with DARA-based therapy, bring that patient into remission, and that autologous stem cell transplantation should be done for this patient. We should not, if a patient responded initially to these drugs, but now also because high-risk disease, plasma cell leukemia is a high-risk disease, should be given a best treatment with DARA-based therapy with 3 to 4 cycles, then autologous stem cell transplantation, and followed by a double maintenance to this patient.
Absolutely. So, let's call it a day. So,
Thank you.
Thank you so much, Dr. Mallikarjun and Dr. Siddesh, for wonderful case presentation. I think, and I thank also all the discussants over here to join today for this webinar. And now meet you next week, next Saturday, Sunday, for another beautiful webinars. Goodbye for now. Thanks a lot.
Thank you. Thank you.